episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome, everybody, once again to another episode of our show. We're bringing you another fascinating guest today who's helping to create a better tomorrow on many different fronts. Today, we have the honor of being joined by Dr. Corinne Leach, who is a gerontologist, digital health strategist, and behavioral scientist who serves currently as the senior principal scientist in behavioral research at the American Cancer Society. Dr. Leach leads survivorship research on behalf of the Population Sciences Group, serving as their principal investigator of the American Cancer Society survivorship cohorts and the ACS-lead for the American Cancer Society National Cancer Institute online self-management platform known as Springboard Beyond Cancer, which is a really novel eHealth tool that helps to empower cancer survivors to better manage their symptoms, to live healthier, and ultimately improve their communication skills around cancer, as well as other chronic health conditions, both during and after treatment. Dr. Leach's cancer survivorship research focuses in the area of aging, in the area of cancer-related symptom assessment and chronic disease self-management. And her research ultimately aims to improve the understanding of the various behavioral factors that contribute to healthy aging, the best ways to promote them, the unique experiences that are found in older cancer survivors, such as physical late effects, psychosocial issues, and various ways to improve survivor self-management. Dr. Leach also studies accelerated aging after cancer diagnoses, including the accumulation of these multiple chronic conditions after cancer diagnosis, and she evaluates the benefits of health behavior interventions such as chronic disease self-management. Dr. Leach is part of the Gerontological Society of America as a fellow, a member of the Cancer and Aging Research Group, Scientific Advisory Committee member for PAC Health and Dr. Susan Love Foundation for Breast Cancer Research, adjunct professor at Emory Rollins School of Public Health, Susan B. Anthony Yetna Award winner for excellence in research on older women, and American Health Association, and has authored over 70 peer-reviewed publications. She has her master's in public health from Harvard, her Ph.D. in gerontology from the University of Kentucky, and her master's in experimental psychology from here in the Philadelphia area at Villanova. A lot to talk about. Dr. Corinne Leach, thanks so much for taking the time to come on the show today.
Sure. Thank you for having me.
It's great having you. A lot of unique themes that we're going to be getting into today, but I'd love to start things off as we typically do by handing you the floor for a couple minutes just to talk a little bit more about you. If you could take a couple minutes to go into where you grew up, when you developed some of these rather fascinating interests in both gerontology and psychology, and a little bit of the early career journey. I think that'd be great to start things off.
Sure, happy to. So my name is Corinne Leach. I come from Bucks County, Pennsylvania. It's where I was born and raised. Really beautiful area of our country to grow up in, very rural area, kind of sitting up on top of a little mountain, looking down into the valley, gorgeous this time of year in particular. So had a really lovely childhood growing up in rural Pennsylvania. And I had these two really brilliant case studies growing up that fascinated me about healthy aging. So I had my two sets of grandparents. They had very different health trajectories throughout their lives. On my father's side, they had a lot, and kind of looking back at kind of a healthy aging perspective, they had a lot of exposure. So they were both lifelong smokers. My grandfather did quit much later in life. There were occupational hazards. So my grandfather worked in the steel mills in Pittsburgh, Pennsylvania. And they weren't the most physically active couple, and they both passed away rather young. So my grandmother in her early to mid 70s and my grandfather in his early 80s from lung cancer. And then on the other side of the spectrum, you had my maternal grandparents who were incredibly healthy, incredibly active, and lived until their mid 90s. And so they had very different aging trajectories across life. And in thinking back about, what was it about my grandmother and grandfather on my mom's side that helped them to live such a healthy and long life. And what can I learn from that, not only for myself, but to help others to live longer, healthier, happier lives. And so on their side, they walked hand in hand 3 miles a day every morning outside, commonly in nature. They were avid square dancers. They were very connected with the community. They volunteered at church. And then when they moved to a continuing care community in Media, Pennsylvania, they continued to volunteer. My grandfather volunteered to help run the post office there and their video channels and things such as that. So they stayed really active and connected socially. They remained physically active. They had a very healthy lifestyle, not just in physical activity, but also in what they ate. And they were lifelong non-smokers. So they were always an incredible inspiration to me and really drove my passion for having a stronger understanding of healthy aging and how we can live longer, healthier, happier lives.
Wonderful, wonderful. And yeah, Bucks County is beautiful this time of year. I can attest to that because all my in-laws are out that way. I'm sitting down here downtown in the city, and we have some trees, but no, not like Bucks County. But no, that's one, right? I appreciate that background story, Corinne. And one other area I wanted to bring up, sort of as an introduction, especially for our non-US viewers and listeners that may be less familiar with the American Cancer Society. It's an organization that's been around over 100 years now, dedicated to eliminating cancer. And I think most of it, maybe from my perspective, and maybe a lot of the folks in the United States that have been involved with the American Cancer Society, maybe involved in fundraising activities and so forth. Talk a little bit about the organization, but then also where you and your research organization sits within the American Cancer Society, a little bit on sort of where your directives come from. Obviously, your purview has been rather broad in terms of aging and cancer, psychosocial connections in cancer, and so forth. Walk us through a little of that. I mean, where you sit right now and so forth. If you can just give us a little landscape there too.
Sure. So at the American Cancer Society, we have the broad American Cancer Society, and we also have our Cancer Action Network that sits in, that's the legislative advocacy arm of our organization. And so that's a separate entity, ACS-CAN, there in Washington, D.C. I am part of the American Cancer Society, the broader umbrella and organization, and we have multiple pillars. So you were absolutely correct that our due north is creating a world without cancer. And, in particular in the research group and in my group, our priorities are to reduce the burden of cancer. That includes prevention strategies, as well as help with management and improvements in access to quality treatments and post-treatment care for those who develop cancer, for them and for their families. So I am we have several different arms. We have our advocacy arm, we have our patient support arm that I do a lot of work with, kind of in a hybrid type of role. And then we have our discovery arm, which is our research arm. And we have extramural research where we fund grants. That is actually what the majority of our research funding goes to, is to fund extramural researchers at cancer centers, at universities, and this is across the continuum of cancer. So we do a lot in whether it could be drug discovery, whether it could be looking at biological mechanisms in mouse models of cancer treatment to really accelerate how quickly new treatments are happening. But then we also have our intramural research program. And so that includes our surveillance and health services group, and then our population science group. I sit in population science, and we are kind of a multidisciplinary group of epidemiologists, behavioral scientists, biostatisticians, and we in our group have the cancer prevention studies that was designed as an epidemiologic risk cohort, but we are working to expand it to start doing even more cancer survivorship and caregiving research within that. And so that's where the group sits. I used to be a part of a behavioral research center that merged with PopSci as kind of the direction of the organization was more streamlined, especially during the COVID-19 pandemic. And so we have this multidisciplinary approach to population health, which is really exciting. Many people describe kind of the group in which I sit as, well, actually all of research being this large school of public health within a nonprofit world. So it's a very unique place to sit. It's a very exciting place to be. And in terms of where our priorities, and I have done a lot over the course of my career at the American Cancer Society the last 10 years. And that's because the priorities shift. So when you're at an organization like the American Cancer Society, it's very different than being in academia. You follow whatever the key priorities are of the board, the CEO, and down. And so that has shifted directions in some of my work and has also opened up incredible opportunities to do work in areas that being in academia, I never would have been able to. So hopefully we may touch on some of the guidelines work or the eHealth technology development and testing later on in this podcast.
Absolutely. Absolutely. And you know, before you were leading, the behavioral behavioral research component of what you do now. You spent several years involved in, as director of cancer and aging research at the ACS, and your priorities were pretty broad here, and I've gone through some of your papers and different panels that you led, and it really seems that at least I saw sort of these three baskets. One, where you were really getting a deeper understanding of the very unique profiles of an adult cancer survivor, someone that's adult that's undergoing cancer treatment currently, and the unique sort of comorbidities that happen in that patient population. A second part, sort of just the general need for more research at the intersection of aging and cancer. And then, you also went into a lot about sort of the unique, sort of the medical sort of geriatric profiles of what is required in that population, whether it's certain therapies, physical performance, nutritional status, things of this nature. I'd like to just start off with sort of your opinion on where sort of the intersection between oncology and gerontology in 2021 currently, what it looks like. Is there a lot of interaction between these spaces currently, or is it still an area that, as back in 2015, you were encouraging there should be more discussion between these groups?
So fortunately, because of the founding of the Cancer and Aging Research Group by Dr. Arti Huria, and now is being led since her passing. So she worked with Supriya Mohile and with William Dale. And so since her passing, Dr. Heidi Clevin has stepped up. And so it's the three of them who now lead that group. And it is a phenomenal group of brilliant minds working at the intersection of cancer and aging. Many are clinicians, and so they are the ones who are actually seeing patients, doing clinical research to improve the outcomes of their patients. But then there are people like me who are not clinicians, but are really interested in improving the care, improving the treatment and the long-term outcomes of older cancer patients, as well as their families. So I would say it has dramatically changed over the past 10 years and since 2015, much because of the Cancer and Aging Research Group. And we have worked closely with them to develop different infrastructure grants and support the infrastructure grants. A big role there is to increase the inclusion of older cancer patients and those with multiple chronic conditions in clinical trials. Oftentimes the diversity, so racial ethnic diversity, as well as age diversity in these trials is incredibly lacking. So it's not really giving data on those who are experiencing cancer and undergoing treatment on what dosages would be appropriate for them, what their long-term outcomes would be like, toxicities, all of those types of things. So this group has been a huge advocate for increasing inclusion within the randomized controlled trials. And then as well, they've been really interested in the comprehensive geriatric assessment. So I think that is incredibly important, an incredibly important assessment tool to better understand comprehensively what someone's physical health, mental health, social support is looking like as they're entering cognitive abilities, as they're entering into treatment, in order to have a better idea of how best to follow them and at what level of care to follow them. That can also lead to a different type of treatment course depending on their frailty measures or different things identified in their comprehensive geriatric assessment. It helps the clinician know and have a better shared decision-making process about treatment and as follow-up.
What are some, and obviously there's this very unique interaction between aging and cancer. Obviously we see an increase in cancer incidence with age. At the same time, some of the work you've been involved in showing accelerated aging in cancer treatment and sort of some of the negative aspects there. But what are some of the other things that while you were doing that, that part of your research that were interesting to you in terms of where we should be focusing more in terms of the later stage? I had my mother actually fought breast cancer in her 80s. She was a bit of an outlier in the sense that, she drank her two whiskeys and all that stuff, and she got through it, and that was her thing. But maybe she wasn't normal. But talk a little bit about for a little bit more about this population, if you would.
Sure. So many people enter cancer not just with cancer. So they come in with kind of a complex health profile. So they may have arthritis, they may have diabetes. And so you may have also polypharmacy issues going on. And so not all survivors are the same, just like not all cancers are the same. There are so many different types of breast cancer. And so I think that was really something that this work opened my eyes to. Are like oftentimes models look at mean progression of something, and they kind of combine everyone, and they look at predictors of, additional chronic conditions over time. They look at mortality and time to mortality, time to death. And so I think what was really important to me and the direction the field is going in is starting to look at group trajectory analyses of people with different types of outcomes. And what can we learn about people before they start treatment on what they're at risk of developing? So a lot of the accelerated aging, accelerated frailty over time, who's most at risk at being in the steepest, highest groups? And what can we do to better inform interventions and then implementation of interventions to help them be on a lower trajectory in a lower risk group? So I think that is really the direction that we're starting to take, especially with some of the risk cohorts, epidemiologic cohorts that are moving into being also doing survivorship research within risk cohorts, utilizing linked data sets such as Medicare data sets or other types of claims data to have more robust data, pulling in medical records wherever possible. AI algorithms have come a very long way. And so we're starting to be able to build machine learning models that will help build these risk profiles of people so that things are more personalized. So we've talked a lot about kind of in this space, personalized medicine in terms of treatment, but wouldn't it be wonderful if we had better data on someone like this person, this specific cancer patient with this type of cancer, this subtype of cancer, this physical activity history, this age, but not just chronological age, but really how old they are based on a lot of other factors than just chronological age, to know this is the best treatment course for them. These are potential toxicities that may come up. According to that, adjust along the way. I mean, there's such breakthroughs happening because of big data right now, and because of these types of machine learning programs that will dramatically increase kind of risk stratified modeling. So I would say the future is definitely in an exciting one in kind of the risk stratified pathways of personalized survivorship care. And will provide clinicians with the data they've been wanting forever to better have those shared decision-making types of conversations, because it's really hard if you don't have all the data. It's like here's what we know, not necessarily with data that for someone who looks like you, but this is what the overall data looks like. So this is our best guess on what the best kind of moving forward will look like. But over time, we're going to have much better risk algorithms that you can plug data into, and they can provide help with treatment decision making.
Excellent.
Yeah.
As your role as strategic director of behavioral research, one of the very interesting areas in your sort of publication portfolio has been, the connection. Obviously, we've been coming through this pandemic. COVID is a communicable disease, but you've been publishing, obviously, on the important connections that we've been seeing between a communicable disease like COVID and the non-communicable diseases, cancer, diabetes, and so forth, and what we see there in terms of changes in physical activity, in terms of changes in mental activity. And here, one of the papers, one of the recent ones, Perspective COVID-19 related changes in physical activity and sedentary time and association with symptoms of depression and anxiety, that was in Mental Health and Physical Activity Journal. Talk a little bit, obviously the pandemic's hit all of us in terms psychologically, physically, and the way we've changed our activities over time, but talk a little bit about where you've gone with this particular. I know you published quite a bit on it, but walk us through a little bit of what you're looking at here, because it's an interesting, obviously, COVID/cancer connection here as well.
Sure. And this is another example of kind of the uniqueness to being at the American Cancer Society as the pandemic hit. As we were building out a participant portal for our Cancer Prevention Study 3, our newest risk cohort, we were enrolling 3,000 participants in an online portal. And this was around July through September that they responded to an initial survey on our portal. So the risk cohort is 300,000 people, but we were kind of slowly pilot testing, bringing people into this participant portal. That way, as we implemented and brought everyone in, we would have a better understanding of kind of timing and workflow and all of that, and any issues along the way, so we could correct it before doing kind of the large scale bringing people to the portal. So because of when we had that data collected, and we had data collected from our triennial surveys back in 2018, and the next one is currently in the field, our 2021 survey, we had this July to September 2020 survey of about 3,000 participants that we could look at changes in physical activity, changes in mental health, changes in physical health from before the pandemic to during the pandemic. And that was incredibly unique data that not many places had or could leverage really quickly. So the data for the paper that you're talking about comes from this unique data set. Sure. And we were really interested in looking at, so there were two papers that came out from utilizing this specific data. One that focused on changes in mental health from before to during the pandemic, and what factors were associated with larger increases or even decreases in depression and anxiety. And the second paper that focused on changes in physical activity, sedentary behavior, and their association with changes in depression and anxiety. And so we found that, not surprisingly, depression and anxiety did increase during the COVID-19 pandemic, even when we were months into the pandemic, and there was a lot of uncertainty still. And we looked at differences by gender. So oftentimes, if you have a history of elevated mental health issues, especially depression or anxiety prior to the pandemic, you were more likely to have even more increase during the pandemic. Men oftentimes had the work-life stressors that someone had going on and employment stressors. That was associated, especially among men, with higher increases in depression and anxiety during the pandemic. So we looked at a bunch of different life stressors. And then in terms of physical activity dramatically decreased during the pandemic among this population, and sedentary behavior increased during the pandemic. And both of those changes were also associated with increases in depression and increases in anxiety. And so it shows the importance of not just a focus on mental health, but also the mechanisms potentially associated with these changes in mental health. So what can we do? It's getting out and safely and socially distanced way, but being active, going for walks and we picked up golf, and my husband's a huge golfer, but I became more into golf during the pandemic because it was a great way to be out in nature,
Sure.
outside in the sun. It was a little bit social, which was also really helpful. I think a lot of us missed those social interactions. And so
Sure.
it provided that, and it got me off the couch and it got me active. So move more, sit less. It was incredibly helpful. So I think there are a lot of options for people to safely be more active, even as they may still be wanting to socially. It's actually not even socially distance. It's like physically distance from others, safely distance themselves. But so all of that was associated. It was a really unique time to be able to conduct studies like that. And so it was an exciting piece, I would say, to my publication history in order to help inform not only this pandemic, but if we have anything similar in the future, there's a lot of lessons learned for sure.
Absolutely. Corinne, back in 2016 is when the American Cancer Society and the National Cancer Institute launched this important eHealth tool, Springboard Beyond Cancer, free, customizable online tool for people to manage all sorts of both physical, emotional symptoms, mentioning helping to improve communication after diagnoses and so forth. Talk just, if you want, a little bit about this collaboration, how long it took to put together, how long it took to create the tool, who was involved. Take us a little bit into the history of it, if you would.
Sure, happy to. So this was something that we created guidelines for survivorship care for primary care doctors. And in that process, so that ended in 2015, 2016. In that process, we identified a huge gap in the field for providing digital support tool that is free and comprehensive to cancer survivors and their families. And NCI came to us. They hosted smokefree.gov. That's a very large digital platform. So they have a lot of experience building and testing and enhancing digital support tools in the area of smoking cessation. And so they were also interested in building out a comprehensive support tool for cancer survivors. And so they came to us. And so on the ACS side, I was the team lead and worked very closely with Dr. Catherine Alfano. And then on the NCI side, Dr. Eric Augustin was the lead on their side. And we brought in Dr. Shauna Hudson and Dr. Michael Diefenbach, so Rutgers and Northwell Health, as digital support and digital tool creation and research experts. They've done a lot in kind of the digital support world with usability testing and randomized controlled trials. So it was a dream team, quite honestly. It really was a spectacular team of brilliant minds who were really focused on building out support tools to help people during treatment and after treatment in a comprehensive way. So many different types of tools like this had been built out for improving physical activity, reducing fatigue, reducing pain. They were almost one-off pieces instead of a comprehensive approach, which is oftentimes what survivors truly need because things can change on a dime. And we wanted to create something that was not at point of care, which would be in a clinician's office, but really available to them anytime, anywhere, and most importantly, for free, that came from trusted sources. So, I mean, that's one thing that I can definitely say is the American Cancer Society and the National Cancer Institute are both very trusted entities. And that's critical. So it was important that we had the best team possible to build out this digital support work. It was backed by science, so it was backed by evidence, and it was continuously improved. So we worked on that, and in about 10 months, we were able to launch a beta version that we did some usability testing along the way, of course, but then we did launch structured qualitative usability testing evaluation at 2 different sites and published those findings. And so it wasn't just that we published the findings that way, there was buy-in from the scientific community. We used those results in order to build out the 2.0 version. So we enhanced the product so much, both in usability, both in engagement. We had engagement metrics that we were able to follow over time. We added in more survivor videos about topics important to people. We built in more interactive types of tools within the digital support tool. We added a text message component. It was a companion text message piece to the web-enabled piece that someone could access on their computer or via phone. We added in additional modules for caregivers. That was something that was slightly touched upon, but we've noticed that based on our usability testing, we needed to build that out more. Survivors wanted more support on financial toxicity, so we added modules there. And we were able to provide better connections between the survivor videos and the content. That way it was easier for people to navigate. So that happened. And then we launched that and continued to follow that from the back end using just kind of following engagement metrics over time to see how people were using it, what was driving, how they were finding the site, things such as that. And then we did a randomized controlled trial. And that was just published last month that randomized people to either our intervention that was both the web-based Springboard Beyond Cancer, but also the text message intervention companion versus a more static control site. And so we published those findings. It was among those who used the intervention, the digital support tool as intended. They had a moderate effect size, so about almost a 0.5 effect size, which is quite dramatic in improving in their confidence to self-manage a lot of cancer-related issues. And so we were able to find that. There are, of course, struggles with engagement in these types of not just the digital support tools, but also when you build out a research study to actually keep driving people back to your actual intervention and not just filling out the surveys. So lots of lessons learned along the way. And we have a new CEO now, and we're hiring a new chief patient officer. And so things are kind of, now that we have that out, things are kind of paused at the moment for the new leadership to come in to decide the exact direction and where we're going to take this work in the future. So it's kind of a stay tuned for the next year or two to see where we're going to keep moving in this direction.
And for everybody listening, if they want to read that current study, it's entitled "Cancer Health Self-Efficacy Improvement: A Randomized Controlled Trial," and was in the journal Cancer on October 20th. Speaking of what you, I mean, obviously there was an impact, as you were saying, in certain ways, but then other, you mentioned that there are certain components of that need improvement, and obviously these are the early days of digital health, and where obviously digital health is a very hot theme everywhere. But as you're just wrapping up there, what would you like to, obviously you wait for the new management team and so forth, but where would you like to run with the tool next? If once again, if my $1 billion of funding just shows up tomorrow, where would you take next steps with such a tool to improve it?
Sure. So, I mean, in addition to the quantitative RCT results, we also followed up with additional qualitative interviews with the participants. So we have even more data to go off of.
Cool.
So it was always the plan to have a beta version, a 2.0 version, and then continue improving it. So we are in need of a 3.0 version to continue being innovative in this space. And so I would say, I think it's important to use the data to continue building out and improving and enhancing the products in ways that our constituents want and would engage in and are useful in actually driving more positive outcomes. So I would say that's what we would do to create kind of this new digital front door to the American Cancer Society for survivors and their caregivers to better meet their changing needs over time. I would say it would be expanded to an even bigger suite of products and partnerships that we may have with other companies that have demonstrated improvements. If we don't offer it ourselves, that we could partner with other companies that have products that have been demonstrated to improve various aspects of health that go beyond what we at the American Cancer Society can do. So I think a lot of these conversations will be happening in the future, and very excited to be involved in those, and yeah, very excited to see kind of the direction that we're going to be moving in the future.
Awesome.
Yeah.
Corinne, one other question while I have you, obviously you've been at this intersection of gerontology, of cancer, of the behavioral and social connections there. And we do a lot of shows on sort of this theme of health span, of the compression of morbidity in later life with certain diseases. Not an area that's extremely hot yet with the pharmaceutical industry, but slowly but surely ramping up. I was just going to ask you about sort of, maybe your holy grail interest of this space at this intersection. And let's put aside, the CAR T cells and the antibodies and all sort of the oncology direct sort of interventions. What types of things, once again, if I show up with my basket of, $50 billion and give it to you, what are you looking? Are you looking for, what would some of the holy grails be? Would they be interventions for frailty? Would they be some of, the mental health related things at that intersection of aging cancer? What are some of the things that you would like to see develop, or you would like to, develop and then hand over to the Glaxos and the Pfizers of the world to run with? Just to take us a little into the future.
So I think in the future, what I'd love to see the life sciences do more is incorporating PROs, patient-reported outcomes, into their trials. Okay. So not only looking at mortality and serious toxicities, but also looking at overall quality of life, because that is so important to patients and their families. It's not just how long I'm going to live, it's how well I'm going to live. So I see in the future, and what would be phenomenal is if there's also support beyond just the drug intervention to support people to identify some lower level toxicities earlier on so they can adjust the dosage. Because at the end of the day, it's all about adherence. And it's important for patients to be able to adhere to the drugs. And I think that's a win-win both from the pharma side as well as the patient side. And so I see that direction potentially taking place more and more. I see biopsychosocial research really taking off. And so instead of it being very separated, having more data sets and being able to utilize machine learning to dig deeper on the biological side. I think that's huge in the future as well. Oftentimes they've remained separate, but I see more multidisciplinary teams coming together. And in terms of digital health, I think the thing that's really exciting is they're starting to recognize that you need to have evidence that it actually works as intended in order to sell it. And so I see more companies looking to digital health experts like myself who are embedded in research to help them build out the evidence that their product works in order to help scale it up. Because you can have something that's super shiny, new, and exciting, but if it doesn't actually drive outcomes, at the end of the day, it's not going to be a winner. And it's also not creating a healthier, happier place. So I think that is something that companies have started to recognize. There's so many digital health apps out there, and you go on your iPhone and you're like, oh my gosh, look at all these different things I could do to increase physical activity, but what's actually going to help and what's going to keep people engaged? So that intersection between running RCTs and the data to drive outcomes plus user experience, because it could, if intended, if used as intended, drive better improvements in outcomes. But if you are missing the user experience component, people aren't going to use it as intended. And then you're going to miss that mark at the end of the day too. So I see kind of both of those in research, but also in the digital health industry being being the future. And it's an exciting time to be in that space.
Outstanding. Corinne, we've talked about oncology and gerontology. We've talked about digital health. We've gone into COVID and non-communicable disease connections. Have I missed anything that you want to get into? And could you take us a little bit into where we can watch Dr. Corinne Leach in 2022, conferences you're going to be at, talks you're going to be giving? Please take the floor.
Sure. So in 2022, I plan to be at the Society of Behavioral Medicine.
Okay.
That's always a really important conference to me, as well as the Gerontological Society of America next year. And so those are places that I plan to be. In addition, I give talks at various additional places based on kind of whatever comes up, which sometimes is for fundraising, because it's important for our donors to have an idea of how their funds and their generous donations are being used to improve the lives of cancer survivors and their families. And so do a lot of that as well. So I would say in the next year, really building out and utilizing the cohort data is something that we're doing. And then it's going to be stay tuned to see who is hired as a new ACS Chief Patient Officer. Very excited about that. And excited to work with that person to really drive into the future ways to better improve the health and the treatment experience of people impacted by cancer, as well as their families.
Outstanding. Outstanding. Corinne, it's going to be fascinating to continue to watch your progression in this space and what's coming next. You've really laid out an impressive groundwork, everything you've been doing, and just really impressive. And for everybody that's going to be listening to this particular episode across the various podcasts or watching on our YouTube channel, you've been listening to Dr. Corinne Leach, gerontologist, digital health strategist, behavioral scientist at the American Cancer Society and the Behavioral Research Division. Check out the Springboard Beyond Cancer tool. Check out her dozens of publications in PubMed and other locations. Really fascinating portfolio of work. Corinne, once again, I want to thank you for taking time out of your schedule to come on our show. Thanks for everything you're doing there at the American Cancer Society. And as we like to say in our show, thanks for helping to create a better tomorrow through what you do. Really, really fascinating story.
Thank you so much.